And before we dive too much into the content, I want to just go around the room and introduce some folks that we have in the room, as well as our guest presenter. So I am Akira Templeton, the Quality Initiative Specialist at OPCA.
Troy Carpenter, Healthcare Metrics Analyst at OPCA.
Claire Drake, Training and Development Manager. Hannah Kendrick, Training and Technical Assistance Project Coordinator.
Carly Hood, Policy Associate.
Bob Maxwell, Data Team Finance.
Kendra Nickel with Family Care.
Great. And we were going to have someone else from Family Care join, but unfortunately he's not able to today, so Kinda will be presenting for them.
Yes.
Still trying to figure out this mute thing. There we go. All right, so we can go ahead and dive right in. Kinda, I have you off of mute, so feel free to chime in should you want to comment on anything until your presentation.
Okay, thank you.
All right, so most folks on the line have probably heard of the Oregon Primary Care Association, but I know we have some folks that might not be as aware of what we do here, so I want to just start off by sharing a little bit about us. We are a membership organization for 33 community health centers, or FQHCs statewide, and we really provide them kind of technical assistance for any of their efforts, whether that's data, quality improvement, finance, workforce development, on a variety of topics. We also do some policy influence and advocacy at both the state and national level. And just a little bit about the health centers that we kind of provide support to. These health centers generally provide a full range of primary care services, and that includes mental and behavioral health, medical, oral health, and then also just kind of connection to some community services as needed. In 2015, we had about 59% of the patients that our health centers saw on Medicaid and about 19% uninsured. So some of you who are on the line that are not necessarily in the FQHC world, that hopefully gives you a little bit of a picture of the populations we're serving. Some quick logistical items. We'll have about 10 minutes for Q&A at the end of the call. I have actually muted folks to avoid background noise, but we will unmute you, as I mentioned, for any discussions that will come up. But should you have any questions or comments throughout the presentation, feel free to type them in the chat box, and we will address them when we have time. All right, so for today, as I mentioned in some of our emails, this is a follow-up to a call that we had in December around emergency department utilization. And this one is really getting into kind of how you work with your care teams and your patients to engage them in the process of finding appropriate avenues for care. So for today, we'll be talking a little bit about this concept of health literacy and how that might apply to some strategies to impact the emergency department utilization metric. We'll learn from Family Care, a local CCO, about their approach to partnering with care teams and patients. And then at the end of the call, we will engage in some peer-to-peer discussion around strategies, best practices, and recommendations that you all may have. And at that point, I'll summarize some additional findings that I found when researching this topic. And real quickly, a quick review of the various emergency department metrics that are happening at the state and CCO level. So the first one that we see is the emergency department, outpatient and emergency department utilization metric, which really talks about the number of visits that a patient had to the emergency department that resulted in an inpatient encounter. And that is the metric that we are looking at for the CCO incentive metrics, as well as the data transparency project. So you can see the 2017 specifications on this metric by following the link on the slide. But one thing to note is that for 2017, the benchmark has increased. So instead of looking at 39.8 per 1,000 member months, it has increased to 42.9 per 1,000 member months. So we have a little bit of work to do on that. And then the other metric, which is not necessarily a CCO metric, but I wanted to let you guys know of, is the avoidable emergency department visits. And this is a core performance metric at the state level. And really this is just kind of looking at, out of the number of visits to the emergency department, which ones had avoidable diagnosis codes. So kind of thinking about how can we maybe track some of those diagnosis codes and implement interventions to avoid them from going to the emergency department in the future. And this metric was not updated for 2017, but you can see the 2016 specifications by following the link on the slide also. So as I mentioned, in part one, we talked a little bit about kind of some of those metrics, but also talked about the EDI metric, which is the Emergency Department Information Exchange metric. And this was a metric designed for hospitals to kind of foster some collaboration between the hospital and the clinic in terms of communicating when patients were seen at the emergency department. And so the main update around that was that hospitals are no longer required to push notifications to the primary care clinic. Rather, the primary care clinic, assuming you have access to EDI, the information exchange, then you are now required to pool that information as you want to see it. In that call, we also heard from Providence Medical Group about how they have used the pre-managed and EDI data to help avoid ED visits. And then we also heard from an FQHC in Decatur, Illinois about their ED diversion program, which will come up a little bit again today as well. So kind of just building off of that, again, the focus of today is really kind of taking the data use a step further to then looking at the data and then now also engaging those patients. And this was a patient education handout that Meg from Providence had presented on in December, and she was not able to join us today, but we did receive a couple follow-up questions about this document after the call, so I just wanted to route back to that before we get into Family Care's presentation. So the question around this document was, how was this handout developed and how is it used? And then is there any measurable effect of this in terms of how it helps steer patients to appropriate avenues for care? When I asked Meg Linza these questions, she mentioned that this was developed as a part of a campaign for an employer who shares risk with the delivery system and also a payer with employees who have high utilization. So it sounds like it was developed kind of in collaboration between an employer and a payer, and making sure that risks for the staff and risks for patients were all taken into account as they were developing this. This is not a final product, though. They are still working to improve this, and one of the things that they hope to address is to include a map on the back side of the handout that actually identifies locations of express clinics or other types of care that have convenient and easy access for patients. And this would be kind of a handout that they would turn into their patients or in any of their outreach efforts to help engage them in maybe going to express care or primary care versus the emergency room. So if you want to learn more about this and how it's used outside of what I just mentioned, let me know and I can put you in contact with Meg. And the last thing I want to kind of put a plug in before we get Kinda to present is this concept of health literacy. And the definition of that is really around the degree to which individuals have the capacity to obtain, process, and understand basic health information and understand the services needed to make appropriate health decisions. So the reason I bring this up is because not only is health literacy around how do people understand their own health conditions and how to mitigate risks of conditions, but health literacy is also around the patient's ability to navigate the healthcare system and understand what appropriate types of care are, what the options are, how much it costs, you know, how does their insurance come into play. And so really health literacy can get at this kind of bigger idea of navigating the system as a whole. So the reason I bring that up is because I believe that health professionals are really responsible for ensuring that patient health literacy is up to par with what we are communicating to them and asking of them. And so as we go through the slides and discuss kind of this patient education and engagement piece, just think about maybe how health literacy might come into play as you're engaging those patients to impact this particular metric. And with that, I will go ahead and pass it off to Kinda. Kinda, feel free to just let me know when you want me to advance the slides, unless you want me to hand over the control. It's up to you.
No, I'll be more than happy to let you know. Thank you so much. Okay, so thank you. My name is Kinda. I'm from Family Care Health. I guess I'll just say slide. Would that work? So we have been exploring as part of our approaches different opportunities to really reduce the emergency room use by members, but also to help equip them to engage in an appropriate level of care and to engage with their primary care provider. We found that it was more than just educating them and meeting them there in the emergency room, but it was also trying to help introduce and engage them within the healthcare system as a whole, and really about the management over the long term. So we've tried a couple, if I may slide. We've tried a couple of different approaches, and where we are right now and moving forward is two real targeted teams, one of which is what we call our transitions team. And that's really the team that's really multidisciplinary, and they are the ones right now primarily utilizing pre-manager Eddie. So their current workflow is they receive notifications of members, and we went ahead and targeted our 6 hospitals with the most volume of use in the area. And they go through the real-time notification. They look back over the previous 24 hours, of course week independent, and stratify the members according to an internal sort of risk assessment tool that's really comprised of medical components as well as social determinants. And if they score above a certain level, this team will then begin to initiate the outreach and care coordination process. That will include reviewing whomever they might be involved with in terms of primary care providers, if they are aware, any specialists, community partnerships they might be involved in, and also with the facility itself. So first, assessing what they have perceived the needs to be, for instance, the discharge coordinator, and if there is a need for our presence and if we can help partner with them, and if there's any barriers to accessing care. A secondary mechanism we have built into this is our use of our utilization management reviews. They offer a different lens, so while we have that more social determinant focus, if UM also identifies other components that might increase a member's risk for a return to the ED or a return readmission, then they also send a notification for the team, which they will also follow. The transitions team is really designed to be very targeted. It's all about partnering with the member, helping to get to an appropriate level of care, and helping to facilitate access with their primary care provider and whatever other associated community providers that they have, of which there's usually involves a multiple, disciplinary care team, and just really kind of fostering that communication. And they only follow them for upwards of 30 days outside of when they transition, very targeting the discharge from the inpatient facility to home, and then sort of reinforcing from there on out, and whether or not they need ongoing care coordination, which kind of brings into our second program, which we identify as our PORT system, and that stands for Patient Provider Resource Teams, and that's a little bit more comprehensive. I have the structure of the transitions team up on the slide. That's 3 RNs, an addiction specialist, and a social worker. The PORT, however, is a little bit more expanded to offer different levels of intervention, so member navigation, provider relations, utilization management, a service coordinator, and a care coordinator as well. And they're a little bit more focused on not only the long-term management, but also the small pieces of letting a member know who their primary care provider is, offering them opportunities to change providers, particularly as they are auto-assigned right now according to the current system. And with them, the transitions team is highly mobile. They're really about community engagement. In the PORT, the care coordinators are also mobile, but the rest of the team is really there focused to offer that on-site, at-home-based sort of interventions around just the daily management of a health plan or CCO. Next slide, please. We have been working through with our data, trying to find the best target to really get the biggest bang for our buck. And so this one is really still things that we are exploring as data unfolds, and as we as a healthcare system overall kind of learn more, particularly with the introduction of the health literacy piece. For now, right now, they're stratified according to medical complexity, which we identify as more than 2 chronic conditions. And members with behavioral health challenges to include chemical dependency that are not engaged in care. Some people are really wrapped very well and tightly, while others are not. And the interventions are very much focused on barriers that would impede their engagement in the healthcare system. That's really found in social determinants, health literacy, or just access and an ability to engage. Another piece that among those is we've decided to actually be very specific on targeting 2 other with the pediatrics and the maternity specialty ports. So in addition to the transitions team that's focused on the inpatient transition component, the pediatrics and maternity really just target those specific members and really kind of engaging them on their particular needs, as the interventions tend to be slightly different. Next slide, please. So our program premise really is to utilize presently the teach-back method primarily and motivational interviewing to really sort of target those the social determinants, the health literacy, the education, and we really do try to prioritize the translation between the member and provider to help facilitate the communication. For instance, if a member discharges from inpatient, making sure the provider is aware of that. Any change of medications really kind of, and the med reconciliation is completed, and reinforcement of discharge instructions, and that they do schedule the follow-up appointments. So that communication between not only the providers, but also with the members to get more of a buy-in, frankly, and reinforce alignment towards a shared goal. Next slide, please. The delivery mechanisms we use, all of which I've sort of outlined, but really trying to emphasize that all of these are wrapped around the member. So not only the real-time use of EDI pre-manage and the specialty teams and our community partnerships, providers, and ports, but really kind of how we can be innovative to engage the member where they are at and help them to partner with and really kind of build that long-term relationship with the providers in the community. So like an example of some of those pieces is occasionally a member is really just unaware of where their PCP is, or that if the primary care provider they had in the clinic left, it's astonishing how many members are unaware that they can remain at that clinic and engage with a different primary care provider. Other pieces around that include like the urgent care map. So we actually have a handout we take with us, the team always has on hand, and really sitting down and taking the time with the member, and it has a map located, so this is where our urgent cares are. Where do you often, which one's closest to you, which one do you feel like you're able to get to, which one's by public transportation. So really kind of drilling down in to identify whatever barriers may be present. there's a significant number of members that engage in ED utilization that struggle with homelessness. So really trying to find out where their central location is, where they seek meals or shelter, and just partnering around whatever reluctance they may have, was it a bad experience or what the perceptions were. So it's very individualized and focused on this level, but overall, the upper level piece is just to really offer as many opportunities as possible to engage the member. Next slide, please. In doing so, part of that piece is really looking at next steps. So we've done a lot of exploring and trial and error, and we've definitely tried out different programs to find what would be the most effective piece. We have found that moving forward, the utilization of more predictive modeling, that's really going to offer an opportunity to take a more upstream approach and focus on prevention measures. And with that, we'll do that in partnership with our population health department. So not only will it be offering that education piece and the health literacy and engagement on an individual level with the members, but also making sure that we have a concurrent message on the community level. And in doing that, of course, that includes our community partnerships. So it's very much around how can we engage, how can we find and help smooth out access. So that's one of the biggest barriers we have, is identifying and meeting the member is really not as much of a challenge as getting them timely access to care that they find to be according to their perceived needs and in alignment with their provider's assessments of their needs. So our next steps will also include, we're very excited that we're going to pilot the use of PAM, which is a patient activation measure. We're hoping that the tool is ideally designed to allow more accurate assessment of members' needs for an even more targeted and potentially effective interventions specifically around this piece. And so empowering not only our providers, but empowering our members and our community partners to sort of move forward and actually help with long-term sustainment and overall health. Next slide. So that was a very, very quick and dirty sort of overview of what we're doing here. Does anybody have any comments or questions?
Let me go ahead and unmute folks. All right, the lines are open if anyone has any comments or questions for Kinda.
This is Erin from OHSU Richmond.
Hi, Erin.
Hi, and I was wondering if you could say more, or if you know more about your plans for using PAM. Like which type of role? Oh, and I see there's a question in the chat that's very similar, or builds on my question too.
So PAM, we've only gotten an overview of PAM and what it looks like in terms of application, but what we were able to identify was that it offered a very structured, drilled down assessment of a member's abilities in terms of ADLs and IADLs as they pertain to health literacy. So it's really, and it's part of the interventions that the team does now, but it's offering also cues and a documented assessment piece to also monitor goals and progress. For example, when it comes to medication adherence, it's not simply do you take your medications, it's how do you set up your medications, how frequently do you refill it, and really identifying barriers and needs around that. Is there a need for bubble packs or a pill box, that sort of thing. So our hope is that it offers detailed, consistent assessment to ensure that everyone's actually assessing the same components and a measurable outcomes towards the goal.
That's okay.
Great, and then do you have a role or team member in mind who would be doing the PAM kind of assessment, or is that kind of TBD?
Well, no, we have, right now we're going to, as part of the pilot, we're going to distribute it across our port system, our transitions team, and our population health team, so that we get the very, targeted, very specific short-term team approach, the longer-term sort of care coordination approach, and the overall community sort of systemic. And then from there, we'll assess, which one yields the greatest efficacy and the most information, and we'll take it from there.
Kinda, this is Akira. I'm wondering if you could talk a little bit about how, and you've touched on this a little bit, but how you have, as CCO, worked with your clinics, help give them the tools, the care teams the tools, to then in turn give the patients the tools. Like how are you as a CCO kind of supporting the clinics in that effort?
Well, there's multiple approaches, like more of our provider relations and our utilization management, and so I can only speak specifically to the care coordination approach, and the rest, of course, would be my perception and not necessarily what they would say according to that department. But for us, it's really identifying with, for instance, any of our primary care facilities that have a community outreach worker or a social worker present. It's really partnering with them, updating them on the information. It's an unequal distribution on the amount of primary care clinics that have EDI pre-managed and have that information available. So it's an awareness, this is what we have found, here's our information exchange, and what do you need? So for instance, they may contact us. We have a reciprocal relationship with some of our local FQHCs that have this member, for instance, I'll identify this member's been coming in quite a bit. We're having challenges around helping them manage their chronic conditions, particularly when they have several, and they have difficulties getting appropriate supplies or utilizing, or coming back into their appointments. So, I mean, everyone's sort of variable, so throwing it out there, but it's really allowing them to identify for us what they feel their needs are and for us to communicate with them what we perceive the members and the member perceives their needs are. The port is really one of the main vehicles to really sort of implement this on a longer-term basis, because the short-term piece of the transition is really just facilitating that initial sort of communication and ensuring that it's staying there. But the port, however, will take a more longer-term approach, and those tend to develop more of partnerships between the community health workers, social workers, depending on what clinic you are, and the PCP, and the member. And just really, honestly, our whole goal is just to get an alignment and engagement and then partnership, and then really kind of taking a step back.
Thank you.
Yes, no problem. Our whole goal is to strive for 100% of the integration model.
And we got a comment here in the room just about this kind of topic of health literacy, and the comment was that health literacy can often be significantly diminished when someone is kind of feeling, if they're feeling fearful or if they're feeling sick, which is often why people go to the emergency room anyways, because they're confused and they're sick and they don't know where else to go. And so I'm wondering how you have approached the health literacy aspect in that case.
Well, one thing that we are very mindful of is that we are the CCO, and so we are not the provider. So it's really first assessing where the member is and how they perceive their current status to be and what is really been asked of them. We take a trauma-informed approach to care and very much strongly reinforce that throughout the entire team and within our organization. So what the member, for example, if the member has difficulties or challenges around, let's say smoking cessation tends to be a really common piece, where a member that has COPD, for example, and they go to see their primary care provider and they feel like they suddenly have this avoidance around it because smoking cessation always comes up. Well, of course, that is a key component for their longevity, but it's really then about assessing where the member's at, and if that becomes a barrier to them engaging in care, then it's partnering with the provider or the member, depending on the level of comfort around, yes, we understand this, however, this is a barrier, how can we move forward? So it's not only taking a trauma-informed by the team, but also promoting a trauma-informed approach to care with our providers and in the interaction between our members and providers.
Great, thanks.
Yeah.
Are there any other questions for Kinda, for anyone on the line or anyone else in the room?
Okay, well, thank you so much for having us. I really appreciate it, and I apologize for Ron not being here today. And
No problem. Not at all. Hope he's feeling better.
yes, absolutely. Thank you, Akira. I'm going to go ahead and put myself on mute now.
Okay, sounds good. Thanks, Kinda. All right. So kind of moving on to the latter half of this presentation.
Good. Thanks so much. Are you on your way back? Are you?
Sorry about that. Went ahead and muted everyone again. All right, so this latter half of the presentation is around kind of just some things that I found when I was looking into like what are strategies. I mean, we've heard about the ED diversion program from Crossing Healthcare in December. We heard about the CCO approach just now. And I was just curious, you know, what other interventions and strategies are out there. So I did a little bit of research, and obviously a couple low-hanging fruits that came up were some resources that we have on the Data Transparency Project website around kind of guidelines for primary care and then also hotspotting. So the information on the slide is hyperlinked, so you can just take that directly to the web page. But I also wanted to kind of just summarize a little bit about what those are. So there is this guide for primary care that was developed in partnership with the Robert Wood Johnson Foundation and the Greater Detroit Health Council. And they really focused on communications with patients, so both before and after they visit the emergency department. And so in this guide, you'll find examples of kind of a written policy that they have around access to care. You'll find some sample after-hours phone messages, some information that you can include in new patient materials around after-hours care instructions, and really just kind of making that a point of conversation with each patient that you get in the clinic. So this is kind of a comprehensive approach in terms of you having a access to care policy within your clinic, and then also how do you then communicate that policy and various options to patients before, during, and after hours. And then there is a hotspotting data toolkit, which as I was going through, I realized that I don't think they have updated, so it's a little dated, but I think that there's really some pretty critical information in there still that might be helpful. Particularly, there are some learning modules around kind of cleaning your data and measurements, and really like looking into diagnosis codes to reduce avoidable visits, and some information on how to visualize emergency department data. So for those of you that are using Premanage in particular, I could see this being a good tool just to make sure that you are kind of making sure your data is clean and that you're visualizing it and looking at it correctly. So those are just a couple tools that we currently have on the website now. But I also found some information around a local health integration project. And this was conducted with the Central Oregon Health Council and the St. Charles Health System. And Mosaic, which is one of the F2HCs, was also involved in this project. So I would welcome them to chime in if they are on the line. But really, this was another example of an emergency department diversion program where they partnered with local clinics and identified 350 patients that were high utilizers of the emergency department. They conducted a chart review of about half of those patients and found that the most common diagnosis for people going to the emergency department were abdominal pain, headaches, vomiting, and unspecified pain. And they also found some correlations between these diagnoses and emotional, physical, or sexual trauma. So that was just kind of some basic information that they found when they were diving into these high utilizers. They also found that 1/3 of the high utilizers were currently engaged or had been engaged in behavioral health services. So the idea was that, you know, in addition to there being these kind of common diagnoses, how can we approach this in kind of a trauma-informed way, which you've heard Kinda kind of talk to as well. And so some of the strategies that they found helpful in this project were individualized treatment plans. This was noted as one of the key successes of the emergency department diversion program. And these treatment plans should really reflect kind of how the ease of access for patients and kind of work towards setting a stage of intervention and getting people to utilize different avenues of care rather than thinking the emergency department is their first stop for their particular treatment needs. Another strategy was health engagement teams. In this project, that team included a physician, an RN case manager, social worker, and a CHW, community health worker. They also had behavioral health consultants that would come in, were embedded in the clinics and would come in as needed to kind of have a more holistic approach to the care and intervention piece. So really this project had some great results. The initial cohort averaged 3.75 visits per person less in the first 2 quarters of the project. Patients overall reported less pain, and the patients reported improved satisfaction with patient-provider communication. There was some work that happened also around barrier reduction, like making sure that the patients had adequate transportation to get to the clinic. And they found an overall cost reduction. So really the results of this project kind of achieved the triple aim in their perspective of lower cost, increased patient satisfaction, and better health outcomes. Another thing that I found was from the National Quality Forum, and the particular document I'll be referencing is hyperlinked, but there were some really interesting aspects that they talked about in this handout, specifically around kind of drivers for change and what are some particular quality improvements that you can make. And so they talked a little bit about in this handout, it's just kind of a 2-page handout, but payment reform for providers, which we all know is being addressed in some form or another. Financial incentives for patients. I tried to get all care CCO to present, and we could not find a time that worked, but I know that they have some information around a project they've done for financial incentives for pregnant patients and getting them into the clinic rather than the emergency department. So that could be a possible avenue to explore if you're interested in learning more. And then obviously improved data will be a driver for change. And some of the quality improvements that they discussed, we kind of already talked about, making sure, you know, weekend hours and other hours are communicated to the patients, making sure that they're informed of other avenues such as telehealth or urgent care. Like Kinda said, meeting patients where they're at. So how do we provide, for example, services to homeless where they're at rather than having them to come into the clinic? Other quality improvement recommendations were group visits, telephone consultations rather than solely being kind of an in-person consultation if it's just a quick question. One idea was this idea of retail clinics, which I thought was pretty interesting. And really this is the concept that you can kind of pop up a clinic in a certain area or have some kind of open time for people to come into the clinic without an appointment. And there is some research that shows that these clinics are a lot cheaper to operate than just general primary care clinics, so that could be one way of addressing the issue as well. So given some of that we just heard, as well as from Kinda's presentation, I would like to open up the lines and talk a little bit about, or hear from each other about what strategies you've tried, either from what you heard or maybe something that you didn't hear. What were some of your successes and challenges? Is there anything you'd like to learn more about, and how can OPCA support you? So I will go ahead and open up the lines, and hopefully you've all had a moment to reflect on that, those questions, but we'd love to hear from you, whoever is willing to share. And we do have some feedback, so if you have dialed into the phone, please make sure your line is muted if you're having outside conversations. Does anyone have any thoughts about?
Yeah, this is Keisha Bigler. I'm from the Pacific Source CCO in Central Oregon and the Gorge. I was just curious because this has come up several times in many of our clinics in terms of engaging, reaching, and bringing unengaged patients into the clinic. I know there's been some pilot work for some of our clinics that did some pilot work around this that was really unsuccessful, and so I'm just curious if anybody else has anything that they've tried or anything that's worked or kind of any ideas around that.
Hello, Nicole. This is Rob McChesney. I work out in the YCCO area for Oregon, and I have worked in the past with entities that have done a retail clinic model where they do a spot ramp up of a retail clinic, and then they have it tethered to a PCPCH clinic. And what they are able to connect with each other and then use the HR database to kind of. Can you guys hear me?
Yeah, I am trying to figure out who this caller is.
There we go. Oh, maybe not. Okay.
Right.
So basically, no worries. So basically, what had happened is we had a retail spot that had ramped up, and then we had a primary care medical that had a tether. So they acted as kind of like a miniature urgent care, immediate care, and it was effective because folks, like end of the day, where maybe the primary care clinic might, shut down around 6 o'clock in the evening, that retail location was open. I know the Gorge has some with the geographical topography out there can be difficult, and some of the areas are rural. Has there ever been a approach of maybe having a mobile unit that makes rounds or is available, such as like an RV that's converted into a mobile clinic as a potential solution with a tether to a primary care medical home?
I don't think that has been tried out there, at least not that I know of, but I'm going to ask about that because I'm going to be out there next week. So I know they have a mobile clinic for the Mosaic system here in Central Oregon, but I haven't heard of anything like that out there. But that's a really interesting idea. I like that idea.
Just a solution. I just found that we've had some success with the retail clinics, and it's just a spot like it's out, and we had kind of ramped up for short periods of time, and then we were able to capture those patients and then follow up with those patients through our care teams the following day from the PCPCH clinic.
Okay, thank you for sharing. That's really helpful.
I know that PCPCH applications are due April 1st, and I'm wondering if anybody is planning on renewing their application, and if so, how they might be able to kind of leverage that status to address this issue. Yeah, so the question was, I know that PCPCH applications are due on April 1st, and I'm wondering if there are any folks on the line who are at clinics that plan on renewing their applications, and if so, how might you be able to leverage your PCPCH status to address emergency department utilization? Are there any other folks on the line who want to share any strategies or successes or challenges they've had with this metric?
This is Keisha again. I guess I'll throw something else out there. Something that we've used in our more rural areas out here in Central Oregon is we've been looking at different pilots and rounds of using community paramedics to engage with high ED utilizers, particularly in our Cook County area. And it has actually, we've seen some positive outcomes. We're in the process of evaluating that program formally, but anecdotally, it's worked pretty well. We've definitely seen a reduction in ED utilization by those members that have opted to enroll into the program. And I know this is going on statewide. Our model's a little different than some of the other ones that are going on, but this is something else we've been looking at, and assuming our evaluation comes out positive, we're looking to spread that program.
Great. And I know that Pacific Source has had a huge amount of involvement with this metric. Is that correct?
Yes. Yeah. I'm actually, I'm the Emergency Department Improvement Coordinator.
Okay.
So
Okay, great.
It's all mine.
So we should have had you present is basically what you're telling me.
Maybe in the future, yeah.
I will definitely keep you in mind. Just on that note, are there any particular challenges that you've seen within any of your clinics? And Kinda, feel free to jump in too, but are there any common challenges that you think that the CCO might be able to help clinics address?
This is Kendo. We find that the most frequent request is, at least in this area, is challenges around housing. So there's a big push for the hospital to not discharge to streets, and housing is definitely an issue within the Portland area, and finding measures to address it. So having access to that, particularly around other components of that include members' goals and whether or not they want to be housed. So there's a little bit of challenges on translating between the two, and really kind of expectations. So that we found to be one of our #1 barriers, and a little bit in terms of stigma attached with members finding secondary care for those that have, for instance, a history of IV drug use, and really having behavioral challenges around that when they are inpatient, and then finding an appropriate placement when they need ongoing care is also a bit of a barrier.
Great, thanks. And do either of you from the CCO folks or any other payers that we have on the line, do you have recommendations as to how clinics might be able to approach their CCO if they need support on this issue?
What we often do is we just partner with, for instance, the discharge coordinator or the social worker, community health worker, and help facilitate that process. But we really do empower them to be able to not only resolve it that first time, but to have that resource available to them in the future. So that first one's really initiating the conversation, really trying to foster a partnership between the community resource, for instance, like with a residential facility for chemical dependency or detox admissions, and then the social worker on site, so that that relationship is initiated and then continues to build, so that in the future we are not required to be the middleman. They sort of take it on their own. So it's really about empowering them to get those different relationships. And which is a challenge in this area because there's multiple different programs. They change quite a bit, and they tend to be siloed. So it's really pushing that community building and networking piece.
Great.
I don't want to hijack our webinar or anything.
Oh, you're great.
So we have kind of a unique meeting that has developed over the years here in Central Oregon, at least. Well, aside from within Pacific Source, we have a pretty well-developed care management program, and we have a member support specialist and behavioral health that all kind of and health services specialists that work together to address more social needs for members, our Medicaid members, and we are very looped in with the community. They work closely with the HET team that you were talking about earlier at St. Charles, and we also have this really cool meeting that I believe happens once a month, and it is called the Community Huddle, and basically this is developed over time, but it is a meeting where all of the local community resources come together over lunch and give short presentations on the different services they provide, and it's really focused on a lot of social determinant-ish areas and a lot of housing, assistance with utilities, shelters for women and children. I mean, it lists veterans. It's quite amazing, actually, the group, and I recognize that would be quite hard to do in Portland. I'm actually from Portland, so that would be hard to do there, but maybe I always thought maybe like doing something geographically based, perhaps, or like East, West County, but it's actually a pretty awesome resource, and it connects everybody, so everybody knows what resources are out there when they are trying to assist a member.
Actually, that is a great idea. One piece that we found is that there is one meeting that meets once a month that's sort of facilitated by one of our at Legacy Emmanuel, by one of the social workers there, where all the local community resources that are around like housing, whenever they do a pilot program, one of which did like paramedics with, going out or a nurse going out with paramedics for members calling, high use of calling 911, that sort of piece. And while we facilitate that within our team, maybe empowering the social workers and community providers within the primary care facilities, they might find that to be useful and also start attending and researching that. And they also send out updates on a web serve list. So that's actually a great idea. It's something that I will follow up on.
Yeah, it's a very popular here, and I mean, we get a lot of, the room is full, and it's pretty awesome to connect everybody.
And
if
I like
you ever have any
including
questions about it too, please feel free to reach out, and I can connect you to the gal who organizes that here too, and she'd give you some ideas or anything like that.
Yes, I'll definitely. Yeah. Thank you.
You're welcome.
Is it Kesha? Is that how you pronounce your name?
It's Keisha.
Keisha. Okay.
Yeah.
I'm wondering if you wouldn't mind me including your email address and our follow-up email to the participants. I'm wondering if that would be okay with you. That way they just have an additional contact for some resources if needed.
Yeah, absolutely. That's fine.
Okay. Are there any last comments or questions from anyone else on the line? Is there anything you'd like to know more about that we might be able to provide down the line? All right, well, we can go ahead and start our call wrap-up. If anything last minute comes up, feel free to chime in. Here are just a couple of resources that I thought were interesting. So AHRQ had some great information about a community care coordination pathway. So a little bit to kind of how Kinda spoke about their care coordination is that it's really with community partners and the clinic and their patients. And so how can you start creating those pathways? I thought this was a great little quick start guide. There's a blog that is there that just kind of outlines some of the key results of the health integration project that I overviewed earlier. So feel free to look at that if you need some reading material. And then lastly, there are some upcoming webinars and opportunities. So there's a total cost of care webinar. It would be the second one that Krista Collins will be hosting in May. She has not specifically honed in on a date and time, but if you are interested in attending that webinar, please feel free to reach out to Krista. For those on the line that are participants of the Data Transparency Project, we are having our face-to-face gathering on June 5th, so keep an eye out for that, although the save the date has already been sent out. And then lastly, as I mentioned, the PCPCH applications are due April 1st, and there are some online learning modules and various resources that can help you through that application process if you need it. And lastly, I will go ahead and send the survey link and email follow-up after this call, but if you can take a few moments just to complete the survey and let us know how we did today, what we can improve, and anything you'd like to see in the future, that would be great. Otherwise, we will go ahead and wrap up, and thank you everybody for your time and discussion.
Thank you.
Thank you.
Thank you.